Welcome to this Clinical Explainer, where we're going to break down everything you need to know about neonatal nephrocalcinosis. Whether you're prepping for board exams or you're just about to start a rotation in the ICU, this is absolutely a condition you're going to encounter. So, my goal for us today is to give you a highly structured, visual roadmap for mastering this diagnosis and evaluating your patients like a pro. Let's get right into it.
Here's a quick look at our clinical roadmap. We'll start with understanding nephrocalcinosis, move into pathogenesis and risk factors, cover the clinical presentation, go through the diagnostic evaluation, and finish up with management and outcomes.
So before we even touch the clinical algorithms, we need to ask ourselves a pretty big question. Why do up to 41% of highly vulnerable preterm infants develop calcium deposits in their kidneys? Honestly, it's a staggering statistic. But understanding the why behind this massive incidence rate is the absolute key to mastering your patient's evaluation. The preterm kidney is an incredibly unique environment, and once you understand its vulnerabilities, the whole disease process just clicks right into place.
Okay, let's establish exactly what we're dealing with here. Nephrocalcinosis is the deposition of calcium salts within the renal parenchyma, and specifically we're talking about the tubular epithelium and the interstitial renal tissue. The crucial takeaway here is that the calcium is precipitating directly into the actual kidney tissue itself. This isn't just free-floating stones in the collecting system, which, is what we usually picture when we hear about adult kidney stones. It's a completely different ballgame.
Section 1. Pathogenesis and risk factors.
I want you to think of this whole process as a really delicate pathophysiological seesaw. On one side, you've got your stone-producing factors, right? Calcium, oxalate, and uric acid. And on the other side, balancing it out, you have your stone-inhibiting factors, citrate and magnesium. Citrate is actually a wildly potent inhibitor because it binds calcium into a highly soluble complex. So nephrocalcinosis happens when those promoters simply overwhelm the inhibitors. And in our neonates, especially the very low birth weight infants, this imbalance is almost always driven by hypocitraturia. That's a severe lack of that crucial inhibiting citrate, which happens secondary to the persistent metabolic acidosis that these sick preemies often experience.
But beyond just the chemical imbalance, we have to factor in the literal structural anatomy of a premature baby. As a pediatric trainee, you're going to see this most often in your extremely premature neonates, because their developing tubules are just functionally immature. Remember, nephrogenesis isn't totally complete until about 34 to 36 weeks gestation. So these premature kidneys have a markedly low glomerular filtration rate, which translates to a very sluggish tubular fluid flow. Toss in the fact that very low birth weight infants have a decreased capacity to reabsorb bicarbonate, which makes their urine alkaline, and you've got a problem. Sluggish flow, alkaline fluid, and rapidly proliferating epithelial cells, it's basically the perfect storm for crystals to aggregate.
To build a bulletproof diagnostic algorithm, we need to categorize the etiologies. First up, we look at infants with normal blood calcium levels. They have normal calcemia, but they are essentially just dumping calcium out into their urine. The most common culprit on the ward? Loop diuretics like furosemide. Furosemide inhibits sodium reabsorption, and calcium just passively follows it right out into the urine. Because neonates have super slow plasma clearance for these drugs, that hypercalciuria is prolonged. But you also can't forget the genetic causes. Bartter syndrome can literally mimic a loop diuretic by genetically impairing that exact same sodium and calcium reabsorption. And then there's distal type 1 renal tubular acidosis, which drives severe metabolic acidosis and, subsequently, nephrocalcinosis.
Next, let's pivot and evaluate the hypercalcemic category. This is where high blood calcium inherently increases the filtered load of calcium delivered straight to the kidney. Now, in the NICU, this is very often iatrogenic, driven by aggressive total parenteral nutrition, TPN, that has heavy calcium and phosphate supplementation. But as a diagnostician, you absolutely must keep genetic disorders in the back of your mind. Williams syndrome and idiopathic infantile hypercalcemia are your classic suspects here. And sometimes you'll even see rare endocrine issues, like neonatal primary hyperparathyroidism, which can present with both severe hypercalcemia and respiratory distress.
Now, this is a fascinating area where dermatology and nephrology actually bridge. Sometimes an infant will develop erythematous nodules and plaques, which is a condition called subcutaneous fat necrosis. It's a rare complication caused by localized inflammation following birth trauma, maybe meconium aspiration, or even therapeutic cooling. The vital thing for you to know as a trainee is that this dermal inflammation can trigger severe hypercalcemia. That puts the infant at incredibly high risk for nephrocalcinosis. So always do a thorough skin exam.
Section 2. Presentation and diagnosis.
You have to rewire how you think about kidney stones for a second. You will not see classic kidney stone symptoms here. The neonate is not going to be writhing around in flank pain. In fact, this is overwhelmingly an asymptomatic, purely incidental finding. You're typically going to discover it when a routine renal ultrasound is performed on an at-risk infant, maybe a ventilator-dependent preemie on chronic loop diuretics, or when abdominal imaging is ordered for something completely unrelated. Even their urinalysis is typically totally benign.
Because we rely so heavily on renal ultrasounds to catch these abnormal calcifications, you have to know what normal looks like. You need to be familiar with the normal renal parameters in healthy neonates during their first 2 months of life. Kidney length and renal pelvic diameter vary significantly based on their estimated gestational age. A preterm infant will naturally have a smaller kidney length and a tighter pelvic diameter compared to a full-term newborn. Keeping those baselines fresh in your mind is essential whenever you're reviewing a radiology report.
Section 3. The Diagnostic Evaluation. So you get the ultrasound report. What's your very first step? It's a rigorous chart review. Don't just start ordering labs blindly. Hunt for the specific risk factors we just went over. Review the medication record. Have they been on prolonged furosemide or dexamethasone? Check their nutrition. Are they on a TPN mix with high calcium and vitamin D? Note their exact degree of prematurity and review the birth history for any trauma that could lead to subcutaneous fat necrosis. And finally, you need to talk to the parents. Ask about consanguinity or any family history of renal tubular defects or stone disease, which might tip you off to an autosomal recessive condition like primary hyperoxyuria.
Next up, get to the bedside. When you examine the baby, you are specifically hunting for syndromic clues. Check the vitals for any unexplainable hypertension. Look at their facial structure. Do they have the distinct dysmorphic elfin features that are associated with Williams syndrome? Grab your stethoscope and listen closely for cardiac murmurs, particularly signs of supravalvular aortic stenosis, which again is highly correlated with Williams syndrome. And, just like we talked about earlier, run your hands over their skin to check for any firm subcutaneous nodules.
Once your history and physical are locked in, here is your essential pocket guide for the lab workup. You want to sequence these tests to systematically categorize your patient. Step 1, serum electrolytes. You're looking for hypokalemia and metabolic acidosis, which points to distal RTA, or metabolic alkalosis, which points to Bartter syndrome. Step 2, serum calcium. Let's figure out if we're going down a normal calcemic or hypercalcemic pathway. Step 3 is quantifying the calcium excretion with a urine calcium to creatine ratio. And step 4 is a standard urinalysis to check for an inappropriately high pH or low specific gravity, which would indicate concentrating defects.
Let's zero in on that urine calcium to creatinine ratio for just a second. I want you to burn this exact threshold into your memory, greater than 0.8. Now, infants inherently have higher urinary calcium excretion rates than older kids do. But in infants under 6 months of age, a urine calcium to creatinine ratio strictly greater than 0.8 milligrams per milligram defines pathological hypercalciuria. It's a hugely critical metric for narrowing down your differential diagnosis.
Section 4, Management and Long-Term Outcomes.
The absolute immediate goal when you're managing this on the ward is stopping the offending agent. If this is medication-induced, simply swapping out furosemide for a thiazide diuretic can very often halt any further calcium deposition. Why? Because thiazides actually decrease urinary calcium excretion. If the issue is nutritional, you're going to collaborate with your dietitian to lower the calcium and phosphorus in the TPN. For metabolic causes like distal RTA, you've got to correct the acidosis with alkali therapy like sodium bicarbonate or sodium citrate. And for the genetic conditions, your management really leans heavily into supportive care tailored to their specific metabolic derangements.
Now for some good news that you get to share with the parents. Fortunately, if the nephrocalcinosis is related to prematurity and medications and you resolve the underlying cause, these calcifications frequently disappear totally spontaneously over the first few years of life. That said, these infants are not completely out of the woods the second they get discharged from the NICU. They need really diligent outpatient monitoring. We're talking serial renal ultrasounds annually for the first few years, along with routine outpatient measurement of their serum creatinine and that urine calcium to creatinine ratio to ensure their renal function is staying stable.
As we wrap up this explainer, I want to leave you with a pretty provocative clinical question. While the calcifications themselves might disappear, what is the long-term impact on overall kidney growth and functional volume? The data out there is actually surprisingly mixed. Some studies show no long-term impairment at all, but emerging case series are starting to suggest that extremely preterm infants with a history of nephrocalcinosis might actually end up with shorter kidney lengths and lower glomerular filtration rates later in childhood compared to their peers. So even if the stones vanish, our vigilance absolutely cannot. Thank you so